Hello, good evening, guys. Today I'm back with a topic that is topical fluorides in dentistry. Here you may see that it's written second year, and actually this was a topic in which I had to make a seminar while I was in my PG days, that is in 2018. So today the topics which I'll be including is the history from where it's topical fluorides, from where it is taken, the definition of topical fluorides, the broad classification into professionally applied and self-applied, then discussing about neutral sodium fluoride, stannous fluoride, acidulated phosphate fluoride, indications, recent studies and recommendations. Then I'll be discussing about the revised guidelines from American Academy of Pediatric Dentistry, self-applied fluorides, fluoride dentrifices, newer topical fluorides, fluoride mouth rinses, and recent advancements. Then the history. So here I discuss about the history. First, the topical fluoride, it was discovered by BB in 1941. So he made a clinical study in which he said that 0.1% of sodium fluoride, when it is applied for 7 to 8 minutes, then there were significant results. That is, there was 45% reduction in caries in the first year. And this was done in a 4-monthly interval in first year and 2 months interval in second year. 33% reduction was there after 2 years and 36% reduction after the end of 3 years. Then Galgan and Knudsen in 1941, they said that 3 groups of 7,015 years, that 3 groups of 15 years old children, they were given 2, 4, 6 applications per year. So that also suggested there was a significant reduction in caries rate. Then according to Knudsen and Armstrong, 1942, they did clinical trials using 2% sodium fluoride for 3 to 4 minutes, concluding that caries reduction was after 4 treatments at weekly intervals. So this was taken from a report on efficacy of fluoride varnish in DC prevention. You can take a screenshot or also just message me up. I'll include it in my description box. So Knudsen et al. Also made a discovery, that is in 3 groups of 7 to 15 years of children. They gave 9.3% reduction in first group, 20.1% in second, and 21% in third group. So this showed a reduction in caries respectively, present in JADA, volume 90, February 1975. So there are again few studies depending made by Jorel and Erickson 1965, Swejta 1971, present in American Dental Association Council on Scientific Affairs. So in US Food and Drug Administration also they used professionally applied fluorides as a desensitizing agent and a cavity liner. Moreno in 2002, he recommended that fluoride gels could be used after 6 months. High-risk individuals can receive the gel in between 3 months also. And but in pediatric, that is children below 15 years, that is 8 to 15 years, there was a risk of over-ingestion, and the gels therefore is not recommended in children. Topical fluoride, it's defined as a fluoride that is applied directly to the teeth, especially in children, in a dental caries prevention program by Miller, Keene and O'Toole 2005. Topical fluorides are delivered to exposed surfaces of dentition at elevated concentrations for local protective effect in making teeth more resistant to decay. Professionally applied fluorides include sodium fluoride, stannous fluoride, APF, that is acidulated phosphate fluoride, fluoride varnishes, and fluoride gels. This was taken by Textbook of Pediatric Dentistry by Dr. Nikhil Marwah. Self-applied topical fluoride include the fluoride dentrifies, fluoride gels, fluoride mouth rinses. Neutral sodium fluoride was the first fluoride compound that consisted of 4 applications with 2% sodium fluoride, giving a reduction of 30%. The method of preparation included 2% sodi- uh, sodium chloride solution, dissolve 20 grams, that is dissolving 20 grams of sodium chloride powder in 1 liters of distilled water in a plastic water bottle. Then we can, it is essential to store the plastic bottles instead of glass containers. Fluoride ion reacting with silica, particles of glass forming silica SiF2, reducing the availability of free active fluoride for anti-caries action. So this is known as Knudsen's technique, where prophylaxis is done. Teeth isolated by quadrant or by half mouth. 2% sodium chloride solution is painted on air-dried tooth. There should not be any saliva. Allowed to dry for 3 to 4 minutes. Repeated until all the teeth are treated. Second, third and fourth sodium fluoride application each not preceded by prophylaxis. The fourth visit is recommended for ages 3, 7, 11, 13 years, coinciding with the eruption of different age groups of primary and permanent teeth. Mechanism of action: sodium fluoride reacts with hydroxyapatite to form calcium fluoride, and this calcium fluoride interferes with the diffusion of fluoride from sodium fluoride solution and blocks the further entry of fluoride ions into the tooth, acting as a reservoir of fluoride release. It is a reason that is why it is allowed to dry for 3 to 4 minutes. So fluoridated hydroxyapatite is formed that increases the fluoride content on enamel surface, making it more resistant to caries attack. Chemical reaction is as follows. This is first C8PO4 whole 6, OH whole twice is the formula for hydroxyapatite, resulting in CF2, that is calcium fluoride. It is reacting with an unstable compound, that is calcium Ca5PO4 whole thrice F between hydroxyapatite and fluoride to form fluoridated calcium hydroxyapatite, where electronegative hydroxyl ions are replaced by fluoride ions. Brood then observed calcium fluoride is formed by topical fluoride treatments on acidic or neutralized solution, or by dissolving fluoroapatite in acid. Presented the Journal of Effectiveness of Sodium Fluoride Interfaces. Role of calcium fluoride as a caries-prone product. Calcium fluoride acts as a caries-prone product by formation of fluoroapatite from released fluoride in solution. According to Higachi, when enamel begins to dissolve as a result of acid action, calcium fluoride may precipitate, and this results in formation of phosphate species until an influx is equalizing the rate of precipitation. That is, there should be more amount of remineralization than demineralization. Advantages: chemically stable, acceptable taste, does not discolor tooth. Disadvantages: continuous application for 4 minutes is difficult for the pediatric patient. Follow-up is difficult. Stannous fluoride is used as 8% and 10% concentrations, equivalent to 2 and 2.5% fluoride. 8% stannous fluoride is preferred. The discoveries were made by Mueller and Van Heusen. The first clinical trial was utilized using 2% SNS solution, where 4 applications was given, and accordingly 83% and 23.6% reduction in caries rate was observed. Methods of preparation is, since stannous fluoride is not stable due to formation of tin hydroxide, so as a result, stannous fluoride, that is the content of 1 capsule, which is 0.8 gram, is dissolved in 10 ml of distilled water and the bottle is shaken. Stannous fluoride has to be freshly prepared, as said before. It results in formation of iron oxide. Mueller's technique is the method for application of stannous fluoride, where the teeth is dried, teeth isolated, and paint on technique is done for 4 minutes, and it is given every 6 months. Found in Muthu and Shivkumar. Tin hydroxyapatite, the result, that is stannous fluoride along with fluoride, that is calcium hydroxyapatite, it results in formation of tin hydroxyapatite. That further reacts with calcium fluoride to form calcium trifluorostannate and tin trifluorophosphate, making the tooth more stable and susceptible to decay. This is the chemical reaction taken from the textbook of Shobhatantan. Advantages is it does not have administrative difficulties. Disadvantages: it should be prepared freshly, low pH. Similar as discussed before, APF, acidylated phosphate fluoride, was discovered by 1960s by Broadwell and his co-workers in Boston, Massachusetts. Methods of preparation is that is dissolving 20 grams of NaF in 1 liter of 0.1 molar phosphoric acid. Then 50% hydrofluoric acid is added to adjust the pH at 3 and fluoride concentration at 1.23%, known as Woodward's solution. A gelling agent can be added. These are the background studies by Willock and Cartwright. Horowitz, on a semi-annual basis, was found under similar JADA textbook. Journal. Mechanism of action: it results in formation of dicalcium phosphate dihydrate that penetrates the crystals and allows remineralization instead of demineralization. High fluoride concentration, low pH favors fluoride deposition. This is the reaction that is present in textbook of Shobha Tandon. This is how we apply on the patient from the operator position and apply it for a 60-second. There may be taste changing sensation. Very effective in 2 years, and it results in deposition full fluoride at a deeper depth. Disadvantage is it is acid, sour, and bitter in taste. These are the diagrams. Some studies. Indications for topical fluoride, that is caries active individuals, have to be given. And salivary flow has to be a little bit reduced. Patients with eating disorder cannot take this. Mentally or physically challenged cannot take this. Some articles present in JIS PPD. Another article, comparison of increment in fluoride in art biology. Evidence-based clinical recommendations in Jish et al. Some scientific articles, you can just Google them and get them in AD, American Dental Association, topical fluoride for fluoride. Micro hardness test, depending on the ACP, CPP, cheese, the importance of cheese in preventing caries. Fluoride vehicles, these are the fluoride vehicles: fluoride varnish, Durafat, fluor protector, which can be applied on the floor before giving a restoration. Recommendations is, according to Lencomte, not more than 2 grams of gel should be given to prevent swallowing. 4-minute topical application, saliva ejector can be used. ADA guidelines, that is, topical fluorides can be given in patients who live in fluoride deficient areas less than 0.6 ppm. More can be there. You can check it out in improvised guidelines by AAPD, American Academy of Pediatric Dentistry. Self-applied topical fluorides, that is dentrifices, gels and rinses. Clean Pro tooth cream, fluoride dentrifices, newer stannous hexafluorozirconate. Fluoride mouth rinses can be used. Swish and swallow can be seen from the diagram. Recent advancements, that is a fluoride matrix, copolymer matrix can be used. Fluoride tablets. Membrane device, this is a device, latest device. Hydroxy appetite diffuse control system reference, these are my reference. And this is the end of my presentation today. I hope you guys will like it. If you have any doubt, tell me in my description box. Thank you and have a good day.